It's been an interesting meeting because to a certain extent it follows the trends of where new medications are coming out, where new trial data is available, and certainly in the field of chronic lymphocytic leukemia we've seen quite a lot of work there with the various raft of new kinase inhibitors, different types of kinase inhibitors, different monoclonal antibodies, and reporting from these trials and the use in clinical practice has been very interesting. But in addition to that, they've also been looking at markers, prognostic markers, stratification markers, and we're beginning to see some of the work from whole genome sequencing, the analysis from that, and really doing something slightly more comprehensive than just taking one gene or another gene or one particular protein that may or may not be present into something where we look at more comprehensive sets of data and use that to help decide the treatment or to follow treatment response, which I think is again an interesting thing because we can then move from one of the new medications to a different one as you see clonal evolution. And I think that that's probably one of the more interesting things. It's not just what do we have to treat them with, it's also how might we combine them, how might we use laboratory parameters to help decide what is best for us to do. There have also been one or two other quite interesting things. I went to a very nice session looking at the sort of histiocytosis and the various issues around there. Very much a sort of orphan type area of disease that sometimes comes to us, sometimes goes to the oncologist. We didn't really know, was it a macrophage or was it some other cell type? Was it these histiocytes, where did they derive from? And molecular work is now actually beginning to help stratify and give us an idea of what the diseases are about. They share a lot in common with hematological malignancies, and I think that as we can stratify, so it is that we can start to look at see how we manage them, and I think it's a disease which hematologists or the hemato-oncologists should be taking on board rather than leaving them partway between the physicians, the general physicians, renal physicians, lung physicians, the oncologist or the hematologist. Should be the hematologist.